Hi, Stella.
Hello.
Welcome to the Midlands.
Thank you.
I know
Lovely to
you
be
love it
here.
round here.
I do indeed.
You
Yes,
spent
I
a
do
bit of time
indeed.
down here.
Yeah, I have done, yeah.
Even though you're very well established in the northwest.
Well, my marriage links with my
Yeah.
husband are Midlands. So yeah, I love to come down here and see my stepchildren and have I love the area. Love the area.
Good. That's good. It's nice to have you. So we're going to look today at what does good care look like.
Yeah.
And I know you know a lot about that. So what I didn't know until I started looking into your background a bit more than we've already discussed, was that you started off in the TA. That's when you started your nursing.
Well, I was a healthcare assistant first, and I joined the TA as a healthcare assistant, and I was right through for about 7 years. So after I qualified as a nurse at Edge Hill University, I stayed on in the TA. So I went from private to a lieutenant in Quarank, which is the Queen's Alexander Royal Army Nursing Corps. And yeah, I got a great lot of experience, some lifelong friends from that experience, and something that I value quite dearly.
Definitely. And do you think that affected the way that you thought about nursing? Like, what difference did that make rather than
it's just
maybe
different
a more
perspectives, isn't it? You know, so military sort of nursing field training is very different to what happens in, you know, your every general hospital and your specialisms and stuff. So, but ultimately, it's providing care in just different environments, isn't it? So, yeah, all of it forms part of your life experience, really, and you take all of it, bundle it up, and you move forward with that in your own sort of life and how you deliver care.
And where did you go next after that then?
I did. I was just so healthcare, did my nursing, TA alongside, and then I left the NHS to be a senior lecturer, and I was for 12 years over two universities. Where I look to implement use of simulation. So to bridge the gap between theory and practice is supporting nursing students to have some exposure to certain clinical skills that they might not have on their placements. So we implemented simulation and simulated mannequins technology in order to try and recreate those experiences so nurses have some sort of idea about how to do certain tasks in an emergency environment, for example, because you can't, on placement, you don't know when things are going to happen. So you don't always get that exposure. So yeah, I travelled the world. I got my master's in education, and that was a wonderful 12 years looking at health and social care, but from an academic lens rather than a practitioner lens. So again, experiences that, you know, that you adopt over your life, really.
I think training has always come across really strongly in the work that you do now with Stella Care.
Yeah.
And that kind of clinical practice and bringing that into the fore of how care is delivered. How do you think, how is training really approached, I suppose, in the work that you do now? It's very, you're very structured, aren't you, about the tasks that people need to learn and what that looks like. And then therefore the expectations of practice around that. I think focusing a bit on that kind of training level would be interesting, because maybe that's something that we brush over sometimes. Bit of e-learning here, you know, safeguarding session here where people maybe turn up, don't engage with it. You approach it slightly differently to that, don't you?
Well, we have a blended model basically. So we do online to get that theoretical knowledge from a staff, and then we have face-to-face induction. So we have our own training room, our own mannequin, and all the equipment that replicates community practice, really. And then we have competencies in the field. So it's like a triangulation, really. So from theory to face to competencies, and then you monitor that and keep going in that because it's unfair to put staff out into the field and not be trained properly. And as much as I find online learning useful, it is. It's quicker, it's efficient, but it can't replace face-to-face learning. You know, because those experiences we speak about and those examples that you have in your life, in your career, that you can give to somebody to make them understand why we do what we do. And that's where online learning doesn't do that. So, yeah, the face-to-face learning is vitally important. So our induction programme lasts quite a long time, because it's only fair that the care staff are supported, are trained adequately to go into people's homes and deliver care.
Yeah. So training is one of those very important ingredients that make good care. What else do you think creates good care?
I think it depends on your perspective. And good care, when you think about the word care, it's very broad, it's very general, and it means different things to different people. And over the years and of my experiences, I find that good care, you'll get a different response from anybody that you ask. And I think from an organisational perspective, like your NHS and your big organisations, I think good care is around your policies, your frameworks, your guidelines, your procedures, your cost effectiveness. They see it that way. But if you ask the patient or the client, their idea of good care is, because they know what good care is, they know when they get it. And when I've asked my clients about what they think good care is, it's things like communicative, empathy, and being human. So good care is a great question, but it's very different depending on who you ask.
Yeah.
And I think that's where I find good care. You have individuals within big organisations that try and do good care by having that empathy, by communicating well, by saying, I'm really sorry you feel that way, let me try and help you. Just the simplest of words, the simplest of actions can make a whole big world of difference for somebody receiving the care. And I think over the years in my experience, I think we may have lost those basic human forms of being good communicators and showing that empathy and having that human touch, because that's where when you look at some of the negative responses where people don't feel that they have good care, it's because they haven't had those three. And so, yeah, I think it's good care it's different for different people, but the essence of it has to remain human, and people like to feel as though they are listened to and people care.
Yeah. And I think particularly in your line of work, in home care services, that kind of time and task focus as well has maybe brought us away from that human element.
Yeah.
That, that feeling that we can sit with somebody and look into things and make sure they're okay. Actually, we've got a list of tasks to get through, and I've got a limited amount of time to do that.
Yeah.
How do you stop that happening? How do you you're a very good leader with your team. We can see that in the outcomes that you deliver. How does that filter down into each and every visit?
Because it's cultural. So we set the culture from the get-go, and the standards that we set are very much geared towards the client and their feedback, not the tasks we have to do. That's secondary. So yes, we have got tasks, and we get our local authority contracts and our CHC, and we have our private clients, and we have a job to do. But they expect us to deliver on what they want, and then we have to deliver that. There's no getting around that. But culturally, if your staff have adopted or in a culture of the client comes first, then that's where you can blend the two and manage the two. So our recent PAMS inspection was excellent, and I firmly thank you. But it's because the staff gave good feedback. The clients gave good feedback. So yes, as an organisation, we have got our procedures, our policies, our guidance, our ways of doing things, because we're a regulatory. But of course, we're all governed under regulatory expectations. That's fine. But at the same time, it's very much about it's what the client felt. And they feel that they're looked after and cared for, and we meet their expectations. So there's no reason why you can't complete the tasks, but do them in an efficient and friendly manner.
Yeah.
It's how you do it. It's the approach.
Yeah.
If you're going in, I've only got 15 minutes, I'm off.
Yeah.
Of course, you're going to get a grievance, aren't you? But then if you're there like, oh God, I've only got 5 minutes or whatever, but what can I do for you in that time? Please let me finish something for you. Or is there anything else you want me to do? Come on, I don't mind. It's how you say it. It's how you say it. And part of our training is very much about those human experiences and how we expect our staff to be with our clients in the community. And I think it's just everybody knows what the standards are.
Yeah.
And I think that's important.
And that's that role modelling, isn't it?
Yeah,
like what you see is what you do.
Yeah.
And if that's the culture that you are creating, then that's what you'll get out the other end of it. How does the nursing and the nurse-led aspects, the clinical practice, how does that feed into that and improve perhaps? Well, I think there's two sides of this. I think there's the client experience in the sense that you're taking hold of tasks maybe that a traditional social care model wouldn't really absorb. So you're keeping things within your team that generates a feeling of they're being looked after, they're not being shuffled somewhere else, that kind of thing. But then I think from your commissioning perspective as well, surely there's an appreciation of the fact that, again, you're taking on extra work. You're taking on some of the responsibility or the steps towards the kind of clinical side of care and practice that actually means that there's less draw on services and the impact that has. So it's really important, isn't it, in the work that you're doing, and you're seeing great results from that.
Yeah.
On a day-to-day basis, what do you think, how does it differ? How does it look different for people?
Well, when I first left the NHS and set up Stella Care, I was very passionate about having a nurse-led model. When I did my research, it was things like the Boortzorg model in the Netherlands, and you have other inspiring companies that have tried to do things differently and be innovative. So Stella Care was always set up with the treatment of disease, disorder and injury as a regulation, as well as personal care. And with myself being a nurse, our registration was quite quick. It was quite smooth. And over the past 5 years since I've been going, I just think the demand for nurse-led care is growing in the fact of that people are living older for longer and not necessarily healthier. And they have a myriad of complex conditions now. And when I go back to my kind of many moons ago, when I first qualified as a nurse, I worked on coronary care. And it seemed simpler then. It probably wasn't, but it was just more people came in with a cardiac issue. It was dealt by cardiac nurses. It was treated by, cardiac consultants and registrars at the time. But now, it's a myriad of complex conditions. It's not as well as cardiac issues. It might be respiratory issues. It's mental health issues. It's maybe learning difficulties as well. So I think nursing has changed. It's more blended in its roles. And for me, we've adopted, and for Stella Care, a blended role model. So all of my staff are trained in any delegated task that I need to in order to meet the needs of the client, learning disabilities and autism, as well as the traditional personal care model, so we can adapt easily. And I think nurse-led care just means that you are there to teach, you are there to educate, you are there to provide that training of those skills that are needed, but most importantly, you can assess the competence. So the people would want to do nurse-led care, sometimes they find it very difficult because there's nobody that would sign off on those competencies for their staff to do. But we're nurse-led care's in-house. So we deliver all of that, and we can monitor those competencies and make sure that the care is adequate and the training is adequate. So we can meet those more complex needs of people, clients, living older in the community for longer. And nurse-led care on the other side of things also means that we can be more proactive. So we are identifying disease sooner. So to give you an example, our care staff will go to a client. One identified that was some hematuria, blood in the catheter. They called we've got a live system, so we do live incident forms, come straight into the office where our nurse triages everything. And then one point of access, going to the GP, district nurse. We'd already got a sample because the staff already know, I think we need to. So it's just that upskilling as well as staff.
And speeding things up.
Speeding things up. So we'd already got that on board. District nurse got involved. GP got involved. We had antibiotics prescribed. We picked them up the same day. So within a 6-hour period, we've identified urine infection. We've liaised with our community partners, GPs, district nurses. We have picked up the prescription, put it on our EMR. So we're getting that medication, those antibiotics, to that client within a very short window of time. And if you think about that, that is quite... We've stopped sepsis, potentially. Yeah. We have prevented further pain for that client. We have prevented an escalation of that situation, and maybe prevented hospital admission and sepsis long term. So that's our day.
And how important is it that was at home, in their own environment? Nobody had to transfer anywhere to do any of that. It was just picked up, dealt with.
Yeah.
And have you got good working relationships with your local GP?
Yeah. Yeah.
You were able to talk their language, which I think is something that's been fed back to me before with the work that we do, is that having the data and the information available to say, this is what's happening, is a much different scenario than... I'm a bit worried about this person. I think there may be a problem. It's looking a bit like that. It's all a bit hazy, isn't it? So, so you can't really react to that very quickly because you've then got to go and do the investigation piece. But you've already done that.
We've already done that, and we've taken it one step further with regards to an initiative that Liz Blacklock and Dr. Kirsten Prothero have looked into, and we're developing an app, Care Boodle, and it's all aimed at our carers in the community are not nurses. They're, as much as they work for me and it's nurse-led care, they're not nurses. They're not qualified in that. But it doesn't mean that we can't use their observations, their feelings, their understanding, my client's not too well today. What's up? They can't maybe articulate that. So this app will help them to articulate with our frail clients, especially causes of delirium. So it could be that taking that one step further from that UTI example that I've just said, equipping all care staff with an app that will go through a pinch me tool very, very quickly, that will feed into the office that we can actually then look at and determine and send to the GP that assessment complete. So it reduces that time for the GP to then phone or pass the questions. It's hopefully quite clear.
I've seen it. It's really straightforward. I really like it frames the questions really well, doesn't it? So it's easy questions that they could sit down with the person and ask the client how they feel about this, the pain thresholds and levels and all of that, the diagrams that are involved. It's really, really...
And you've only seen a prototype. There's a lot more to come with it. But the idea is to equip care staff to identify or to help articulate why they think the person in front of them is not too well, so we can just escalate quicker and allow that process of recognition, being proactive, and being, it works perfectly for us because we're nurse-led, but it's not just for that. It's equipped to support all the care staff out with personal assistants working everywhere. I don't think there's much to support them in that. There's no standardized training really for carers. There's no set qualifications as the core skills, but they tend to be done online. So I think it will help with the training, the support for carers, and then just as a business per se, really adopt a more proactive care approach, because that's where I think the future is definitely heading. When you think about neighbourhood teams, the government are very much are talking more the language of moving from secondary care to primary care, everything being more community based. Well, home care providers, we've got a job to do.
Yeah,
absolutely. Really have.
And do you see that as the future? A really significant shift in the future of care is that actually home care becomes very much the important place to be.
It has to be. I just don't know. I don't know how we're going to meet the demand for care in 10 years' time. So, we're going to have, an elderly workforce that, as I said earlier, not necessarily healthier. We've got that more demand. We can't keep throwing money at bricks and mortar to build residential and nursing homes. They have, of course, have their place. Of course they do. But not everybody wants to go into those.
Don't want
and
to
research does suggest that 87%, would rather be looked after at home. So, and with the community focus, I think we're in a time now where the spotlight should be on home care and looking at the workforce and how we can upskill staff, how we can be proactive, how we can contribute to ONS figures with regards to reducing hospital admissions, how we can be more proactive and looking after people in their own home, because that's where they want to be. And if home care can't do that, well, I don't understand. I don't know who is.
Yeah.
I don't know who is.
Absolutely. You've already mentioned technology that you've introduced, and you've got digital care records as well with your team, haven't you? How significant have they been as tools really to enable an efficient workforce? Because as you've said, we're already stretched in terms of numbers of our workforce already. Numbers are growing in terms of who wants to be supported at home and in community. How important has the technology been to enable?
We're 100% technology based because it's a form of communication. But like all technology, it's only as good as the data you put into it. So it's very much about how it's used, how it's utilised, and how you can get the best out of it. Sometimes in the early days when I first started, I thought, I need this bit of tech, I need that bit of tech, I need that bit of tech because that doesn't do that bit. And it's come on such a long way now that you can have, we've got AI technology as well. And I think we need to utilise and really embrace technology. It's such a useful, powerful tool to, like my reports, those kind of things. I can say how many times you referred to a GP, what the trends are. That informs the training, and we just gather the data, from what we've seen, so we're able to use it. And that's another thing. I think people have tech but don't know how to use that data afterwards to support the future and support that change and how to do things differently. So yeah, it's just part of what we do. It's part of our culture. We embrace technology.
And it's a far stretch, isn't it, from the days of old? I mean, some services still operate in this way, where we've got paper records of every client in their own home. How do you as a manager collect that information quickly and efficiently in order to understand what needs to happen, or to audit, or all of those things? It's life changing.
It'd fill me with dread or bits of paper everywhere. I'd be like, well, I'm quite I like my data, I like my stats, and I like to know where I'm up to. But you don't get excellent on a PAMS inspection if you don't know what you're doing. And the only way to know what you're doing sometimes is to get that feedback. So everything that you're doing to get the data to support it is what's effective. And if you use that data to drive change and do some things differently, that didn't work. Well, we know it didn't work. We can see it didn't work. So how can we do something differently? And I think, but I'm very positive in my outlook, and as a person, I like change. I like adapting. I'm already thinking 4 or 5 years ahead already, thinking about what that's going to look like, and we're putting the steps in place now to support that, because it's reading a lot, it's understanding where care is at the moment and what the future outlook will be. But yeah, that's just part. I love figures basically. I don't know how people can't, but they are trying to make sure everybody does go digital by 2026. They've extended it a bit. It should have been 2024, but I think there's about 20% of care companies that are still paper based,
which just logistically is surely puts you behind now because of the amount of time it takes to just collate that information manually. You've already touched on it. You are thinking ahead. You are kind of 4 years ahead, I think. Definitely a few steps ahead. In terms of your next thoughts around how monitoring data can fit into that? And that's the kind of conversations that we've been having, isn't it, about looking into that? How do you think that's going to add another layer to what you do?
So building on the nurse-led model, so we already have a clinician within home care, and we are using technology in order to get the data, in order to support the care staff to deliver the best care. So that's how it works. So we are quite proactive, very efficient, and supporting cost savings and reducing hospital admission. We already have a friend of mine, Dr. Kirsten Prothero, on board with regards to, we offer all of our clients a one-to-one with our GP. So a proactive approach that they can speak to her once a month, and she can have a review, look at the medications, make sure that they're okay. That will feed into a report with Stella Care that we then change the care plan. So we're really focusing on that proactive approach with regards to looking after people better for longer in their own home. One step further now would be looking at that tech further. And if we can monitor people in their home for 24/7, we are then looking at identifying trends with our clients. We are looking at that reassurance. We are looking at how we can monitor and make the client feel safer in their own home. And with people going in, plus the GP, plus the technology, that triangulation for me is quite a remarkable package of care. And that is something be quite new on the market, because what we tend to have is traditional care, and then we have a big gap, home care, and then, well, we have traditional home care, then we have a big gap, then we have residential, then we have nursing. But that big gap, for me, we can enhance the home care and make it a serious step. So people think, they tend to, currently what happens is, oh, home care is not adequate enough for me now, I'm going to have to go into residential or nursing. Well, let's just put a package in place that encompasses an enhanced package of care that utilises technology, clinicians, nurse-led care, and maybe then keep people at home for a lot longer.
And the traditional kind of monitoring centres that we see around that kind of telecare that exist in every local authority, they exist, but they're about a kind of singular, rapid response to a certain situation. So I've fallen, I'll press my pendant, somebody's on the end of the phone, and they can deal with that. But it doesn't really link into the day-to-day monitoring of what, or observing of what's going on for somebody, like, as you've suggested in other observations. You know, if there's deterioration, how can we get in there quicker? Actually, that's just strengthening that, isn't it? And looking at people's activity. And an emergency response is good in emergencies, but what we're trying to do is take that 4 steps backwards, isn't it? And actually create a preventative response rather than we're dealing with a crisis now. And how much more expensive is crisis than prevention? We know this from some previous examples. Well, sounds good. I'm looking forward to working on this together.
And I think just one more point on that, although my brain stopped working now. If you think about the data that would generate them, and the data sometimes is really, it is most of the time very, very powerful. So if we're spotting trends and we're using that, the deterioration of the client, but then we have got the clinician involved and we've got the nurse and how we manage that escalation with the carers. The amount of data that would generate with regards to, people's patterns, the trends, frailty, what causes delirium, when are people falling more? Is it at night time? Is it in the day? What factors are contributing to that? Because we monitor them 24/7.
And then you've got a really active risk assessment, haven't you? Where you can sit back as the registered manager and say, I can see that these 5 people are at high risk at the moment. We need to keep a better eye on this. We need to change at the times. You've got a really good viewpoint, haven't you, around, potentially where risk exists and how you can manage that and deliver better.
And for me, that's important. But I'm clinical in my background, in my thought process. I mean, there is some argument where somebody has come up to me and went, well, what about just traditional home care? There's a place for that too. And this is nothing about moving away from that, because it is just more for me, moving forward, nurse-led approach, having and integrating fully technology, health, social care together is where we're going to have that true integration, and really have a true idea about what the best outcomes are going to be, and supporting the client and what their expectations are better, and keeping them in their place of preference, and that would be in their own home.
Yeah, brilliant. One of the things that I've always observed about you is that I don't observe you continuously, just occasionally, that you're very vocal about your workforce. You're very vocal and passionate that you have a fully overseas workforce, and a lot of male staff, perhaps because of that.
Yeah.
How does that fit in with, good care, and why has that been your approach?
Well, going back to COVID times, there was no alternative than to that approach. Looking back, we had a massive surge in demand for care at home. The hospitals were closing. There wasn't enough carers. There wasn't enough care companies. It was quite obviously for everybody an absolute chaotic time. And when they put skilled workers onto the shortage occupation list with the Home Office, was the first thing I did, because we have to meet the needs of the community somehow. Somebody's got to deliver this care. Where am I going to get the care staff from? It just didn't happen domestically at that time, and so since 2021 I've had a sponsor license, and ever since, my workforce has been majority migrant workforce, and they've been the absolute backbone of Stella Care. And yes, we've got good CQC rating, excellent PAMS, as you keep saying, very proud of that. But that's where the migrant work from. So good care, it doesn't have a colour, a race, a creed. It doesn't, because people, going back to what I said at the beginning, people know what good care is, and they know that when you feel it, and that's when you have that empathy, communication, that human touch, and that's all what my care staff have given. It's been a hard journey. It's not been easy, but then it wouldn't be for anybody during that time anyway. And we've taken a lot of lessons learned. We've improved our training, because at the beginning there was assumptions that, they knew how to cook and things like that, for British people, and they didn't. And that was a failure on my part, not recognising that. And so I took that really seriously and revamped our whole training section, because we have to. They need the support. You can't just bring people in and get them to work, but without the training, it wouldn't happen anywhere else in any other industry.
It wouldn't.
So there was lots of lessons learned there, but it's gone full circle now. I think because we have assumptions that care is given, that the females are the most caring, natured, and yes, I totally agree with that.
There's an element of mothering there.
And I can understand. I totally can understand that. But it's interesting now, whereas my clients at first were a bit dubious and a bit wary about having males and having a foreign workforce. But now I've got female clients asking for male carers only.
Yeah.
It's gone full circle. And I think that is because the male care workers are more nurturing, they're more softer, they're more gentler with women. And my client, I went to interview her because I was fascinated about why just the male carers. And it's awful because I don't want to put bad name on the female carers. It isn't that at all. But she was just very much, oh, they're just nicer, they're kinder with me, I love them, don't send me the girls, I mean it, I'll leave if you send me the girls. And you just think,
yeah,
wow,
it's interesting.
But it puts your slant on the perspective of good care then. It's not just from women.
No.
It's obviously from men.
Yeah.
And it's how you deliver those core principles of making somebody feel as though they're cared for. And I think that's all people actually care about. People receive and care. You know, you think about, you go into hospitals and, you know, you don't tend to choose genders and races and all those kind of things.
It's not an option, is it?
It's not much of an option in my view. And in home care, if you've got a nurse training your staff to be good carers, what I want the rhetoric to change is that I am training good care staff. I'm removing male and female out of it. It shouldn't be part of that discussion.
Yeah.
Because you're going to get good care, and it doesn't matter
who it comes
from. But I am training good care staff.
And some of that comes from the culture that you've created, I think. It's that value. I've seen plenty of posts where you went to one of your staff members' wedding in India, and you talk about, you know, the importance of valuing each and every member of your team.
Yeah.
Surely that, you know, shines through in the care that they deliver as well. If they feel valued, then there's a knock-on effect of that.
Yeah, and you have to value your workforce, and that goes for any workforce, not just the health and social care sector. And I believe that you've got to try and get the best out of people, you know, and make them shine as best as you can. And it's difficult because we have got our regulations and this, that and the other. But what comes through in our assessments is the fact that the staff feel valued and understand that we're trying hard to make things as best as possible under difficult circumstances.
Very difficult.
And you create a team mentality. And that's where, you know, we work as a team. I can't do my job without my care staff. They can't have a job without having an employer. We have to work together.
Yeah,
we have to work together, and we've done that really, really successfully. And all our feedback is with, as I say, a migrant workforce, 90%.
It's brilliant. It's good. It's a good example, I think, for all of us.
Yeah.
Okay, so what's next for Stella Care? We talked about Care Boodle.
Yes.
So any more there? So
we've just got a prototype at the moment. We are looking for people to adopt and have a look and use the app initially, just to help us, you know, reframe it and make sure it's absolutely perfect for the needs of the organisation and for the carers. We've been in talks with various people because they're quite keen to, let's have a look what it's about. So we are looking at early adopters to come and support us in that development of the app. We're working together with regards to having that triangulation and an enhanced package of home care, looking at 24-hour technology, clinical and nursing all together to make sure that we're getting the best care for the clients at home. A care ambassador for championing social care. So I help support the Care Sector's Got Talent event, which is good fun. I really enjoyed that and being part of that group. I'm board of directors for Partners in Care. So I've lots of things. I do love keeping busy, and I do love but I think the biggest thing that I'm championing is the implementation of nurse-led care and how benefit it can be, and how it can have its benefits on multi-faceted ways, from the care people experiencing and receiving, from a statistics perspective, from a cost-saving perspective, from an upskilling perspective for your care workforce. We have nursing students that come on placement with us because we have a nurse within our organisation. And the nurses are going out with the care staff. The care staff are learning from the nurses. The nurses are learning from the care staff and about the people. We have occupational therapists coming out with us on placement. Because we support that again. I suppose it's my links with education years ago.
And you can see that thread through everything.
It's a thread. Yeah, absolutely. It's training, it's learning, it's experience, it's exposure.
Yeah.
We cannot work in our silos.
And that's exactly it. You've somehow managed to join up education, health, social care into one brilliant circle. It's pretty impressive. But I think that's it. That's what's required, isn't it? To
connecting the dots.
Yeah, to start working. And this is what ICBs are aiming for, isn't it? Is to start linking those two sides together.
Yeah.
Because there absolutely is crossover between the two. And when we separate them, all we do to the person is say, oh no, sorry, my bit ends here.
Yeah.
Now you need to go on to the next person.
Yeah. Yeah.
And I guess that's what we're hoping for with the 24/7 monitoring is actually home care becomes the central point at which you can access all services. Do you think that's possible?
I'd love for that to happen.
Me too.
Absolutely. That's the missing link, I think, when you look at communicate. I think communication is the missing link between health and social care. And when we talk about integration, there's no system that does integrate.
No.
So if you think about technology, then it'd be great if there was a standardised NHS system that us as a care provider on a framework with our local authority can actually access that data for the clients. I mean, we phone GPs sometimes in the early days and say, can we have some information on oh no, we haven't got consent. And God, we're their care provider, we're looking after them. And it can be quite obstructive with regards to trying to get data.
Yeah.
And so that's where the repetition
and
where that time is wasted trying to find out information. Whereas we could access a system, a standardized system from a client, and then we remove access after that.
Yeah.
Then how much easier would that be? It would save so much time in administration. When we have to do our assessments, we go out and go and do a bespoke care assessment. We have to start from scratch, but they've already had that at some point. Somewhere we can get a lot of that data and
going
use
back to the person's experience.
Yeah.
I've told this to one person, now I'm telling it to another person and probably another person thereafter.
Yeah.
And actually we're not thinking about that experience for the individual. It's a lot of exciting stuff coming up then.
Yeah, I think so. I think so. Yeah.
Can you tell us then, just to kind of sum up our conversation today, the building blocks of what good care looks like for you?
Good care for me is based on all of my life experiences, all of what I have seen, good and bad. And I firmly believe that people know what good care is. And as I say, it's different depending on which perspective you're looking at. It's very different from an organisational level. But when you speak to your clients, good care is just about valuing and listening to the client's needs and making sure that you complete tasks, because they are tasks, unfortunately. It's how we do things, but with good communication, with empathy, and really not losing sight on the fact that it's human to human interaction here. Yeah. And that, I think that's what good care is. We cannot lose sight on those basic human traits.
Brilliant. Thank you, Stella.
Thank you so much.
Today. It's been great having you.